All right. I want to talk a little bit about how our bodies absorb energy based on the underlying degenerative state we may or may not have, and how that plays a role in how we manage a case and what the cause of the injury might be. This patient is 14, and she was at one of the jump gyms doing a backflip and landed on her head. Anyone want to comment on what they see wrong with the x-rays and MRI?
It's not quite straight.
Not straight. A very astute observation.
Anterior thesis of 6 on 7.
Yes. 2, 3, 4, 5, 6, 7. We see a anterolisthesis at 6, 7. Good. Anything else? There's a disc herniation, large disc herniation. Scott?
Facet hopped over.
Jump facet. These facets are aligned, and this one is not. So this patient had bilateral jumped facet joints at C6, 7 due to a fall on her head. Same injury that would happen if someone dove into a shallow pool or had another type of fall. I've seen it in a variety of situations. Going over the handlebars in Costa Rica would do it as well. So let's talk briefly about how you would manage a case like this. What would you do? She's 14. She's in a adult-only hospital, and she's technically a pediatric patient. You are the brand new neurosurgeon at the hospital. Don't want to ruffle any feathers too much when you first start. So what would be the management? Yeah?
I don't know the management, but I have a question.
Yeah.
Is the medical term that the facets jump, or is it a dislocation?
Dislocation,
So
yeah.
The medical term would call it dislocation.
Yeah, they're dislocated. People usually will say jump facet. Perched.
Is this something that you retract and reset?
Yeah. Very good.
Do you get worried about the spinal cord being stretched? Like, how do you?
Good question. A little bit, yeah. But definitely want to reduce anytime there's a fracture or dislocation, want to reduce the problem, and definitely concerned during the reduction of potentially injuring the spinal cord even more. She does have numbness and tingling in her upper extremities. Her hands are really weak. She's able to move her legs, but they're also weaker, and she feels numbness basically from the neck down. Morning, Ben. I saved you a seat. Oh, Matt, yes, thank you.
I think the bigger concern after you reduce it is the ligamentous integrity. We know there's a ligamentous.
They're torn, yeah. Totally
it's
torn.
Not a stable segment
Yeah.
at that point. So reducing it in and of itself, I think, is a step, but there's probably more that needs to be done.
Yeah, I agree. So I told the OR and the ER when she came in that I would prefer not to put her on an ambulance or helicopter and transport in that state. She had an incomplete spinal cord injury. I thought we had a chance of making her better. And she was really right on that border with adult versus pediatric. So I took her to the operating room. We had her on the table under some anesthesia and just pulled on her head, felt a pop, took another x-ray. She was reduced and did a ACDF. Funny story about this one is normally in this situation you'd want to have high blood pressures for spinal cord perfusion. And in a 14-year-old, to achieve that, you would need some medication, given IV. So they transferred her right after surgery to the pediatric hospital. And we just launched a new electronic health record in Intermountain last week. They were doing the same thing back then. And when we went to check in on her about 2 days later, the EMR said that she had passed away. And we were really shocked by that. So we called and found out that it was a discharge to deceased done in the EMR. She was totally fine. And that the pediatric hospital had discharged her from the hospital a couple of days after. She had full return of function. 90+% of patients that have bilateral jump facets are going to have a spinal cord injury, probably a complete spinal cord injury. She was 14, had no degenerative change whatsoever. This was purely a ligamentous dislocation, and had a full recovery. So think about, go ahead, Brad.
Another question. With the ligaments being torn,
Uh-huh.
does that mean there's CSF leaking?
Good question.
Patching that needs to happen?
So you could tear ligaments in the spine and not affect the dura. You could fracture the spine, and I've seen fractures that have torn the dura. Usually it's a burst fracture that splits the lamina, and then the dura gets caught in a split laminar fracture. But it is uncommon to have a spinal trauma tear the dura. And she did not have a dural injury. When we did the cervical fusion, do you remember this case, Scott? This was like 10 years ago. Yeah. I've never presented it, but it happened about 10 years ago. The pop, I'll never forget. It's like, this is my first introduction to chiropractic. I can do a manipulation. Yeah. Hey, good morning.
Every day for us.
Yeah, I know. It's like ever since then I've wanted to change careers, but oh well. Okay, so this guy has a history of ankylosing spondylitis, and he chose to get up on a ladder, which is not advised when you have this condition. So what do you see on this image? This is after surgery, so maybe focus on the first two. So we have CT, and then we got an MRI, and there's a particular finding on the MRI that's important, and then this is after surgery. This is blood. Anybody with ankylosing spondylitis or an ankylosed spine, an autofused spine that fractures, MRI is valuable because the fracture can bleed, and it can bleed a lot. In his case, it ended up in the prevertebral space, but it can also end up in the epidural space. So we want to know. So yeah, this is actually acute blood, and it was nice that it wasn't in the epidural space.
Count as a fracture with ankylosing plexus fracture 5-6.
Yeah.
Posteriorly, but it's like fragments of the facet joints or spinous process or.
Yeah, so this would be maybe the leading edge of the lamina of 6 and 5, and it's fractured. It was fused, and it fractured. So the fracture also extends through the disc space. This disc space right here, this disc space, looked like this prior to its fracture, but now it's totally disrupted.
Looks like there's a lot of spinal cord compression.
Oh yeah, he even has maybe a little bit of a contusion. Time to wake up, Scott. Just kidding. Okay, so also fracture dislocation, right? The fracture is very different. He probably extended his neck, maybe, and it just broke, okay? In order to reduce this fracture, we put him back into kyphosis. you don't like to do a fusion in kyphosis, except in this situation, because it's impossible to reduce it unless you just let it settle back in. And all I did in surgery was flex his head, the fracture came right back together, and put a plate on the front. I had to bend, normally we fuse in lordosis, so this plate had to be bent the other way so it would stay on the spine. He also had a subdural hematoma, by the way, that needed surgery, so he got a big subdural and a broken fracture dislocation of his neck. Nice guy, and I told him to not get on the ladder again.
What's the clinical decision making of how many levels to fuse? How do you decide you're going to do
Good
2
question.
levels versus 3?
So in this one, he's already fused at all these levels. So we're talking about trying to get the level that fractured to heal, right? And how many points of fixation above and below, because we're not actually fusing all of those levels, they're already fused. And it seemed reasonable to me if I just did this bone's not particularly strong. If I just put screws 1 at the 5-6 level, I didn't think it would be strong enough. And Todd agrees, which means I was right. Because he knows about fixation a lot better than I do. Anyway, and so we went and put 2, well, it's really 4 screws, 2 on each side, above and below. Yeah?
I was just going to say, in fracture care, we've done all these biomechanical data. You basically take the thickness of whatever it is you're fixing. So let's say this is your femur, right? And it's broken like that. You'll take the thickness of that, go into 2.5 diameters one direction, 2.5 diameters the other.
Okay.
Is the minimal amount of repair that should be done. In general, it's usually on a big bone, 4 solid screws on each side of the fracture, or on a smaller bone, 2 to 3.
Okay. Interesting. Because this is a little different, right, than a normal spine fracture. It's a little bit more like a femur fracture because it's already fused. It's a solid, big piece of bone. So yeah, thank you. That's really helpful. I did not know that. Steve?
With ankylosing spondylosis, what are the chances that it's gonna actually just take? Because, the bone's not strong. You go down, like Dr. Pitts said, a little bit to make sure that the screws are in there. But
Yeah.
what's the reoccurrence like that you're gonna have? Do you know?
I did the surgery, so what do you think?
Well, I
Just
think
kidding,
it's probably
kidding.
good, but
They fuse very, very readily. They just fuse. That's what they do. So I think if you can get their alignment reasonable and you've got decent fixation, they're likely to fuse. One interesting thing about this is I hesitate a bit to put him in a collar, even though it's a fracture. Why would you think that's the case?
just he's already so stiff there.
Okay.
But I don't know.
Anybody think, what would
Maybe
be
a
the
different position that he would fuse in or something?
yeah, what would be the problem with putting somebody with this fracture in a collar?
To force them into a lordosis.
Yeah.
Into a
He broke.
normal.
He broke an extension,
Right.
and you're putting him in extension with a collar. So we actually sometimes don't want him to wear a collar. There's fractures in the thoracic that happen, a big autofusion in the thoracic that fractures, and they need to be more in kyphosis to get that to heal. Spinal deformity for kyphosis would be a completely different strategy, but when we're treating a fracture, we don't really want them to open it back up. So yeah, that's a good question. So if you were to look at these two situations, this 14-year-old girl that fell on her head and this 65-year-old man with ankylosis who also fell on his head, what's different?
Pre-fracture.
Okay. Pre-fracture, pre-injury. The girl has great flexibility. The gentleman has completely stiff spine. Bone quality, yeah, very good. A young person's ligaments are very strong, but so is their bone. So for them to injure either one would take considerable force. She tore right through the ligaments, but the bone was just fine.
Really doing a revision, wasn't it? Because you said he was already fused.
He fused on his own.
Oh.
His medical condition led to autofusion. So that's nice that we weren't doing a revision surgery, because that would have been even more complicated. We actually had one where just about a month ago, a patient had a prior ACDF. They had taken the hardware out and done another level, and then he fractured through his prior fusion. So that one was a revision, and we did the same thing.
Bone density might also be an issue.
Yeah, so the bone quality, the bone density of the older patient was poorer than the younger patient. Steve?
I think just healing and the comorbidities go with it too, right?
Yeah.
14-year-old's got good, strong, it just was a freak accident, right? This guy, we don't know what's going to happen because of the 65-year-old and the comorbidities that come with it.
Yeah.
So it's just a little more of a precarious case.
Yeah, the girl after a spinal cord injury, because this guy maybe had a very minor spinal cord contusion, which is probably never minor, but the girl had a true central cord injury and was out of the hospital within a couple days. This guy was in the hospital for a couple weeks. He also had a subdural hematoma. But yeah, the post recovery is significantly longer for patients with comorbidities, more complicated. On the other hand, a first-time ligament injury can also be very, very painful and take a long time to heal in a young person.
I think from a rehab standpoint, I'd be really worried about the guy with ankylosing spondylitis being mobilized too long. You want to get him moving slow, but not be immobilized. Just like you were saying, like you put them in that neck brace, he's obviously in lordosis, but also he's fixed.
Yeah.
It will cause complete loss of neck range of motion as well. So getting gradual movement through his neck would be really
He already had complete loss of neck range motion before his accident. He couldn't. It's
motions.
Yeah. I mean, his entire neck is autofused. He can't move it at all.
Even C1, or
Yeah, it goes all the way up to the top. So, yes,
that's
which
why
is
it snapped like this.
That's why it snaps like that. Yeah. Yep, that's exactly right. When you've got a long segment autofusion that absorbs a force, it's going to snap and be highly unstable. Kind of like if you compare a green branch of a young sapling to the dead branch on a mature tree. How do they absorb force? One snaps, the other bends. If it bends far enough, it'll break, but it's a different kind of thing. And so really everyone's musculoskeletal system is on that continuum from sapling branch to mature to maybe a part of it that's very brittle. And when those brittle areas absorb energy, they just break. And we have to take that into consideration when we think about management. What was the mechanism of injury? What was the underlying or pre-existing condition that the patient had? And how do we manage? One of the questions that we sometimes get asked is, this patient had a pre-existing problem. So therefore it was the pre-existing problem that was the cause of the injury. So in either of these cases, would you say that a pre-existing condition was the cause of the patient's fracture?
I wouldn't say causal, but contributing.
Contributed to, yeah. And I agree that the stiffness of that patient's spine probably made him at higher risk of falling and at higher risk of injury in a fall. So it needs to be considered as a part of the big picture, but at the same time, had he not fallen, he would not have had the fracture. So we see patients that are in accidents or have falls or other kinds of work-related injuries, and there's always this sort of debate: is it their pre-existing problem, or was it the fall or the accident or the work incident itself that caused the symptoms that they're dealing with. Yeah.
Did his, fusion before protect the cord though? I mean,
Yeah.
To some degree, just the fact that he fused and was stiff already, and when he fell, it could have been where he skipped facets or something and caused more of a spinal cord injury.
Say that again?
He has a big bone essentially. That protected the cord now.
He has a big what?
Big bone, big long bone, because he was already fused in the cervical spine.
Yeah.
If you didn't have that fusion, there would have been more mobility. Maybe you would have had more of a traumatic injury to the spinal cord.
That is a good question. I don't know. The spine protects the spinal cord, whether it's fused or whether it's mobile. Its function primarily is to protect the spinal cord and nerves. Second other function is to maintain mobility. He's lost mobility, but in this case, in order to protect the spinal cord, we wanted him back into his original alignment and fused state, because this injury would have been, if we had not treated it, would have led to further spinal cord damage. Is that kind of what you're getting at?
No, I'm just saying because he was fused already, it created a harder, immobile. It's just hypothetical, not.
Yeah, I think that it might be the opposite that's true. The more immobile the spine is, the less able it is to absorb energy, and it fractures, and those fractures can injure the cord. So both patients obviously had spinal cord issues, but this guy just fell off a ladder. The other girl did a somersault and landed on her head. Had he done a somersault and landed on his head, he might have had a much worse injury. I'm not sure, but there's a very big difference in how the system absorbs energy. Yeah.
In both of these cases, you remedied the dislocation by pulling on the head or the neck. In cases where you can't do that from a surgical perspective, what options do you have for
internal reduction? So there's external and there's internal. So in orthopedics and in spine, I think if you're able to reduce a fracture without an incision, you would choose to do so. And you can pull and tug and flex. And the other day, we were in this, it was the same case I was talking about. We were doing the patient that fractured through a prior ACDF, but no hardware was in there because it had been removed. And we got down to the fracture, and there's a big gap in the bone. It's not like there's a gap there because of taking a disc out. It's just a gap where it fractured. And so we had the anesthesiologist flex the head by manipulating the head of the bed, and it reduced the fracture. So I congratulated him on reducing the fracture for us. But so in a case where a patient has a jumped facet joint and you cannot reduce it with manipulation, you're better off going posteriorly first and reducing the facet just open, because once you have it exposed, you can manipulate. You could even remove the facet joint, put screws in and pull it back. But if you try to go in from the front before it's reduced, you're going to have a long day, because that's very difficult to reduce from the front when the dislocation's in the back. It's a very good question. Yeah.
I don't know if you have this in the spine, but in orthopedics, let's say if we're dealing with a femur fracture or a distal femur fracture, that's very difficult to get all the bones together. A lot of times we'll put traction pins into the tibial, proximal tibia, and then in the proximal femur as well. It'll distract us.
Yeah.
We call it distraction pins. I don't know if you have something similar.
Absolutely, yeah. We put pins in a cervical all the time for degenerative treatment and for fracture treatment, and put distraction on it. It allows us to restore the disc height, to get a better alignment. If you've got somebody with a slip, it'll naturally restore that. Last week, a patient was in a competitive paragliding competition, and he had about a 50-foot fall. They thought he was going to die, the organizers of the event. And he had burst fractures at L2 and L4, both of which had significant retropulsion. And we put screws in and then distracted on a cobalt chromium rod, and we used fixed angle screws, and then did the CT after, and his fractures were back into their alignment. We didn't actually have to go in and remove any bone or risk bleeding or dural tear from that decompression. So yeah, definitely a similar strategy. Yeah.
When a patient comes in, how much of the story do you get before you've treated this person, for example, the 50-foot fall or the backflip or the falling off the ladder, and how important is that story?
That's a really good question. Probably not as much as you would think. I think in my job, these consults and things are coming at you pretty fast, and you're always busy while they're coming. So my wife sometimes will ask, well, how many kids did they have? Or, like, what color was the paraglider wing? I'm like, I have no idea. I really don't know. I should know. But we don't always know all the history. I think ideally we would get as much of the story as possible. It's fun to know. It's fun to know that this patient was from Canada and was here for a competition, and they want to get back home, and how do we arrange all of that or whatever. And the girl that had the accident at the jump gym had a history of some mental illness and had a history of cutting, which is why the issue of her being discharged to deceased sort of was alarming to us. And so yeah, it's great to get as much of the particulars as we can. And sometimes, in 10 seconds you can look at this and say, gosh, ankylosing spondylitis, we just need to fuse that regardless and get an MRI to make sure there's not a hematoma. That's a good question. I hope that these two examples give you the continuum of the spines and the orthopedic extremity injuries that can happen depending on the nature of the patient's musculoskeletal system prior to the injury, because they absorb energy very differently. And then it was great discussion on strategies for reducing a fracture. Are you able to manipulate it? Can you put it in some kind of a traction before making an incision, or do you need to surgically reduce it and manually or with pins into the bone get it into a reduced state? And then in both cases, we want to fuse or fix or treat injuries to the spine and orthopedics and get them back into their proper alignment, which in his case is where he was before the accident. Thanks again for everybody that came to the conference. I felt uplifted. It's fun to connect with everybody. I learned a lot. I thought that, I could list off many, but just at the end there, Todd's how is the spine, how stiff is the spine, and how does it relate to hip replacement was like, oh, I had no idea about that. That was really helpful. And I could go on about all the things I learned, and we'll be in discussions with each other, I think, for some time to come on all of that. But appreciate everybody's time up there, and we've got a great community, a lot of good people, and it was good to have you again here this morning. Thank you.